was there, but that was, and I didn't dig up the cheesy music, but they played "We Are the Champion" as they all marched online, and that was last year's HIMSS. The theme was "Champions of Telehealth," or "Champions of Health Unite." And so I want to thank you for being on the front line as we go through this pandemic right now. And I liked the theme so much that when we did our Upper Midwest Telehealth Resource Center conference last July in South Bend, that I used champions, telehealth champions, as our tagline. So we've done introductions. I'm going to talk just a couple of minutes about the National Consortium of Telehealth Resource Centers and explain that, and then the Upper Midwest Telehealth Resource Center. We're going to spend the majority of our time doing kind of a telehealth and technology 101. We're going to touch just a little bit on federal Medicare rules and reimbursement, and basically what it is, and then what's changed right now, different waivers for the COVID-19 pandemic. And then I'm going to spend more time really talking about Illinois telemedicine rules and what's going on now with the executive order. And then I've got some pre-prepared Q&A that we'll go through. And then, as Anita said, go ahead and be sending your questions in via chat, and Desmond and I will take those as we go.
And just briefly, this is Desmond. One thing we really wanted to make sure to bring to you all this evening was really tactical and strategic resources for you all, so you can take this and turn right around and apply it to your practice. Whether you are a PA who is suddenly in a position where they're being told you are going to do telemedicine, or you're a PA who's perhaps in a position to lead an effort to sort of build, design, and launch telemedicine in your practice. And I suspect and hope we probably have folks in both camps here this evening.
Well, I'll get to that later. So the National Consortium of Telehealth Resource Centers is funded by HRSA. So under Health and Human Resources, Health and Human Services is the Health Resources Service Administration, and then the Federal Office of Rural Health Policy, and then the Office for Advancement of Telehealth. And it's that Office for Advancement of Telehealth that has the Telehealth Resource Center program, and also several other telehealth programs throughout the country. So as you can see by the map, every single state in the United States is covered. The Pacific Basin, they will tell you that they cover an area that's not really landmass because it's mostly water, that is larger than the contiguous 48 states. They also cover Federated States of Micronesia, Guam, and American Samoa, and some other territories. But the Upper Midwest Telehealth Resource Center, I'm located here in central Indiana, and we cover Illinois, Indiana, Michigan, and Ohio. As you can also see here, we have 12 regional telehealth resource centers, and then we do have 2 national telehealth national centers, one for telehealth policy and the other for telehealth technology. And I'll speak more about them as we go through the presentation this evening. The 14 of us altogether have formed this National Consortium of Telehealth Resource Centers. We do have a common website. Some of you may have participated last week in the national webinar that was a COVID-19 topic, but included, previously had scheduled some industry leaders. We had over 9,000 people register for that, and over 5,000 actually participate. So hopefully we can get more questions answered tonight, because we were overwhelmed. I was behind the scenes typing as I would answer one question and have 3 more replace it. So it was pretty crazy. Here at the Upper Midwest Telehealth Resource Center, I refer to myself as a virtual librarian. I spend a lot of time on the computer here in my office, and we answer a lot of emails, we get a lot of phone calls, and we find resources. If we don't know the answer, we'll find it or connect you with someone. And then I do a lot of presentations and trainings like what we're doing tonight. We help folks do project assessments and really try and stay for our 4 states up on what's going on with Medicaid reimbursement and any private payer reimbursement, as well as what, the Medicare landscape across the country. There's several different ways you can get in touch with me. My email will be at the end of the presentation today. Through our website, you can join our newsletter, so make sure to get updates on our events. We're going to be doing a lot more webinars throughout April and recording them and putting them on our website so that people can come and listen to it. They say that you have to hear things 7 times. So for those of you that are totally new to telehealth, don't think that you're going to learn everything you need tonight. Certainly follow up with email to Desmond or I, and you'll have to read it and understand it and regurgitate it a couple times before it sinks in. And then we also have a Facebook page and a LinkedIn page that you can contact us through those. So for those of you that are totally new to this, the terms telehealth and telemedicine are slightly different. I try not to, but I know I probably use them interchangeably. When you say telehealth, really it's the entire field. It could be anything from data from a wearable healthcare device to education, remote monitoring, anything that is combining data and health. And then telemedicine is the actual billable clinical service that is done via two-way audio-visual platform. And I usually stress that it must be HIPAA compliant. We'll get into HIPAA compliance. The HIPAA rules have been relaxed for this particular pandemic that we're in the middle of. If you've got a IT background, you're probably familiar with the term asynchronous and synchronous. So synchronous is when it's two-way, like on a walkie-talkie, if you have a two-way walkie-talkie, or on a cell phone conversation, it's usually two-way. Asynchronous or store and forward telemedicine is just one way. So think about it as sending data, or dermatology is a good example, a picture of a mole or a rash that is sent off to be, or an x-ray, even though radiology is not billed as telemedicine. Those are good examples. When we talk about telehealth and telemedicine, it is not an entire new set of protocols for you to learn. You've been through school, you have your PA clinical license, and this is just another way to deliver clinical services. The services are exactly the same. And we'll talk about, well, with telehealth, how do you get somebody's vitals, or, you can't really palpate a belly, or, those types of things. You're going to have to be creative, and you're going to have to work around it. Right now, we're all doing the best we can with what we have in front of us. So from a telemedicine standpoint, everything that you do in person should be paid just the same via telemedicine as if you delivered it in person. And we'll talk about those details. I already mentioned HIPAA. So we know, and we'll see in the Illinois executive order, how that has been relaxed for Illinois Medicaid. I'm still recommending that clients pick a HIPAA compliant platform. One person that I've talked to, one provider that I've talked to in the 10 years that I've been doing this, has said that they didn't like providing services via telemedicine. So you're going to love it. Your patients are going to love it. You're never going to want to go back. At some point, those HIPAA regulations are going to be put back in place. We are going to get through this. And you're going to want to have a HIPAA compliant platform going forward. So don't choose a quick, easy fix right now, or if you do, choose a quick, easy fix right now to meet the minimum requirements for audio visual. Have a plan in place within 30, 60, 90 days to get a HIPAA compliant plan. And we'll talk about the technology and all of that as well. So I mentioned the National Technology Resource and Assessment Center. This is their website. Here's their URL. They have a ton of toolkits. And Jordan is so patient. He will answer any question you can come up with. And he will talk to you till the cows come home. This is the best website I can recommend. As a federally funded program, I cannot say this is the best program since, or best video conferencing platform since sliced bread. I can't do that. But that's what they do at the Technology Center, or TTAC as we call them. And they give you pros and cons about different things, and it's up to you to do your own due diligence in your organization to pick the best program for your organization. When you click on toolkits, this is what you see. So video conferencing platforms. If this is something that you're going to do long term, you're probably going to want to look into different types of electronic or digital stethoscopes, maybe otoscopes. If you're going to see patients and they're going to, after this is all over with, they're going to be in the clinic and you're going to be remote from them, then there's tons of digital peripherals that you can use and employ to get those vitals digitally.
And if I can briefly, Becky, I think one thing that's really important to sort of clarify here, and sort of what Becky is speaking to, is some of you are in a position where you need to deploy a solution very quickly, and really not overcommitting to something that's going to lock you in to something you can't grow into in the future. So either one, deploying a solution that's simple and functional and lets you serve your patients now, but you can easily pull away from and move to somewhere else, or another that really has the functionality and capacity for you to grow into sort of multiple service channels with your patients, perhaps even above and beyond just video visits alone over time. So this is a really important consideration, and you've got tons of options, is all I can say. If there's one thing a virtual platform should do for you, is it should be user-friendly, both for the provider and the patient. If somehow you've picked a platform that is not user-friendly, then you have picked a very bad solution.
And trust me, there are lots of vendors popping up left, right, and all around us that want to serve you because of this COVID epidemic. I'm getting emails and calls daily. Now, depending on your organization, if you're a smaller organization, maybe you don't have some of these tools available to you. If you're a larger organization, you might have already have access to Epic or Cerner or Meditech or any of the other large electronic medical records. And Epic, I know for sure, does have a video module built into it. Now, your organization may not have purchased that, so you may not have access to it, but a lot of others are starting to add that. Your IT department, you may be a Cisco department, you may be told to use Cisco Jabber or some other type of thing. Listen to your organization. It's a team effort. Or you may be a Microsoft shop. You may be told to go use GoToMeeting. There are, other than a couple of things like FaceTime and Google Hangouts, there are HIPAA compliant versions of just about every single video conferencing platform out there right now. We're using Zoom tonight. There's a HIPAA compliant version of Zoom. Skype, there's a HIPAA compliant version of Skype if you use the business version. Those are just two examples. So, and this, I've got a full hour and a half that I could talk about developing a telemedicine program. But we want to get down and dirty and give you some quick tips and lots of resources so you can come back later. But when I do my full developing a telemedicine program, there's 4 steps: assessing and defining what you want to do, developing and planning, implementing and monitoring. And this is all part of the plan, do, check, act. You might be familiar with that. You might also be familiar with Lean or Six Sigma. Those are great tools to help reduce inefficiencies in your program. And I really like to talk about telehealth as the culture of telehealth, because it's different. And different is sometimes scary. And there's questions and you're not sure, but there's lots of answers. And that's why telehealth resource centers are around, to help answer those questions. So I know I'm dating myself, but in the mid 1990s, I read this book called Who Moved My Cheese? And I love to use this example because it's all about these four guys. And it's hem and haw and sniff and scurry. And if you look at their different personalities, like him as the stabilizer, so he goes at a little slower, methodical pace. He likes a very structured approach. Sniff is our innovator. He likes the shiny gadgets and tools, and he always wants to go and play with the new technology. And then you've got Haw. You know, he likes an unstructured approach, but he's very process oriented. And then you've got Scurry, who just wants to get it done right now. Let's do it right now. And you know, in your organization, I know you've already picked out people that exemplify these four personalities. But when you do a program like this, if you're going to do this long-term over telemedicine, you really want to have a full balanced team, because there's going to be some cost, probably not a lot. You don't need, I mean, you can just do it with a webcam and a platform on your laptop if you want to. But depending how you guys do with, you know, just doing it for a short term, you may decide you want a full-blown program and, you know, really invest in some equipment. But anyway, so you need to know as you work your team and your plan, all those personalities and what's going to help each particular personality to move forward. So we've got all these personalities, and now here we're hit with COVID-19. So now what do? We have to stay at home. We're not, some of you who are healthcare heroes are seeing patients in person still, but for a lot of us, we're social distancing and we're home. So what do you do? And again, a lot of this is, I'm changing my slides here as we move along, but before COVID-19, it was important to have a telemedicine room design, and you would want to spend some time thinking about the room and the lighting, the placement of furniture. You know, if you're in a large healthcare setting, you know, you wouldn't necessarily want to be right by the elevator where they're wheeling gurneys in and out. Paying attention to the acoustics, those types of things. Typically, a patient would be in a patient room that would just have a monitor on a wall, or a monitor on an IV pole, or a cart that was mobile. The patient really doesn't need a lot of room. And I know right now, the patient's probably going to be at home, which is a wonderful thing that we're seeing this happen. So when we see patients from home, we still need to worry about privacy. One of the things I really want to talk about tonight is webside manner, because it's different. You can't reach over and touch the patient. We do a lot of behavioral health. That's just a conversation. It's so easy to convert to telemedicine. You can't pass a Kleenex to somebody, but you could say, you know, hey, do you have Kleenex near, and provide empathy that way. I'm going to talk about video etiquette. I have, and I set up here, I've adjusted my lighting. It's a little, I don't like having my overhead light on, but since it's evening and it's dark, I've got that on. I've got a front lit daylight light in front of me, so I don't have a lot of shadows on my face. I've cleaned up my background, so it's nice and pretty. We'll talk a little bit about consent. Each state is a little bit different with consent. I didn't specifically see anything different about consent in the executive order for Illinois, but you do want to make sure that your patient is consenting. They know that they're getting service via telemedicine. Again, be creative, do the best that you can. You may meet somebody for the very first time over a video platform, and you're going to have to do verbal consent, and you're going to have to figure out how to get to that patient record, or whatever workaround that you've come up with in your organization. We're going to talk about vital signs. How are you going to get those vital signs if your patient's at home and you don't have a tech, a medical assistant or anybody to take those for you? So I'm making some jokes at my own expense here. So this is, you know, don't do this. These are the bad visuals. You don't want to be coughing and sneezing. You don't want your patients to see your messy background. I took these pictures this morning. You can see I have Easterling light, so I was getting a lot of light through my blinds this morning. Messy background. You can see the light here. I didn't have my blinds shut, so this half of my face over here was in the shadows. Same here. That's not too bad there, but I'm looking away from the patient. I'm not engaged. I have 2 monitors on my screen. If I look at this screen, I'm not engaged with you here. If I'm down here writing notes and I don't say, oh, okay, hang on a second, I'm going to make a note, and I make my note, and then I come back and I'm engaged, I'm looking right there at my webcam, and that's how you see that I'm engaged. Yes, it feels weird. It's like being on TV. You know, you have to look at the camera. But that's how, and down here, I'm a private pilot, so that's a pilot joke if anybody's a pilot. You want to look professional, okay? No smoking doobies or whatever. Look professional. All right. You want a clean and uncluttered view between you and that camera. So I've got that here in my setup today. Soft light, I talked about my light here. It's in front of me. It's nighttime, so I'm not getting any light from my windows. I do have my overhead light on, but let's turn that off and see what it looks like.
And actually, for the sake of people who are doing this from home, I actually have some colleagues who have even invested in like a ring light, which you might be familiar with. And a ring light actually, and you really want to kind of perfect your home lighting, a ring light actually will do that really well.
Yeah, absolutely. Yeah, see, I'm a little orange. I don't really like this, but that's all right. Acoustics. So it's not too bad here in my home. I've got carpeting. It helps absorb sound. I don't have a lot of traffic outside right now. My pets are in crates. But if you are in a clinical environment, that can create echoes, high ceilings or hard surface floors. So just be aware of those things. You want to create the best professional look for yourself and for the patient to put them at ease. Some larger organizations that I know, they all have, and I've got a banner in my background, they all have banners that they have to use, and they all have to wear clinical coats and with the logo prominently displayed on the chest, so you know you're meeting with Dr. such and such from, ABC Hospital. Wall colors, again, this is not something you're going to mess with right now if you're doing this just during this particular pandemic, but some guidance for down the road.
Can I add something about the credentials that you just mentioned, Becky? Technically, in the state of Illinois, 1, you always have to identify yourself as a PA in a patient encounter, and 2, it has to be clearly displayed. So it has to not only be stated, but it has to be visible in some way as well.
Thank you. All right, so I'm gonna try and keep this brief because I know you've got lots of questions and I want to get to those, but I just can't help myself. I'm a policy geek, so Medicare pays the same all across the country. They pay based on CPT code, and we'll talk about some of these conditions that have been waived, and then Medicaid. Each state can run their Medicaid program as they see fit, but they're often modeled after Medicare programs. And as of last year, about this time, all 50 states and DC do cover telemedicine for live and interactive telemedicine. It is reimbursed. So this was the story before COVID. Now it is no longer the story. Let me go back. So the patient had to be basically in a rural area or a health professional shortage area at a designated clinical site like a hospital or a rural health clinic. Those 2 things are now waived during this pandemic. Medicare, however, did not waive the CPT codes. They did not add, they added 2 codes for testing of COVID. U0001 for hospitals to use, to bill Medicare, Medicaid, private insurance, and then U0002 for hospitals doing the testing to bill the laboratories. But other than that, no codes have been added, and they did not expand the traditional list of eligible practitioners. Also, so this is the whole rule thing and the rules for that and how you find that is waived right now during this pandemic. And you guys will get all the slides with all that information. This is the Medicare Bible. This is for telehealth. This is the annual Medicare Learning Network telehealth fact sheet. Here's the link to that. This year it's expanded to 13 pages, but it tells you everything you need to know about billing Medicare for telehealth. This year it does include an alert about COVID. It talks about the 1135 waiver expansion. There's fact sheets and frequently asked questions that you can get to from this fact sheet. I've also got all this stuff posted on a special COVID-19 resource page on the Upper Midwest Telehealth Resource Center website. When you look at the CPT codes, this is just a snapshot of some of the CPT codes that Medicare does pay for. They're basically your E&M codes. If you're billing a service today in person, it's probably on this list. Basic billing, and I'm not going to get in too much more detail here. We're going to switch to what's going on in the state of Illinois. But this is what it looks like when you bill for a telemedicine visit. Normally, and I didn't do my little cross hatch on this. Normally the patient it's either called the rural site or the patient site or the originating site or the spoke site in telemedicine language, and they would normally have to be at a clinical site. That gets billed the facility fee. So right now, patients at home, we're not billing this facility fee because they're in their own home. They're not at a healthcare facility to bill that. On the provider side, this gets billed on Part B Medicare. It's your normal professional fee, so the normal CPT code with modifiers. Medicare wants the place of service 02. I heard there was some talk today about a CR code, but we did find it in the FAQs that they do not want any special modifiers or coding from Medicare. It'll be different when we talk Medicaid. But so this is your urban site, typically your distant site, hub site, or provider site. Any questions particularly on this slide? Okay, I'm going to try really not to do many more on billing. Just some fact sheets. You may have heard, if you're following all the Medicare waivers, about virtual check-ins, and this is what they're talking about. These codes, if you follow these links, and this is our National Policy Center, the Center for Connected Health. Got some great graphics and policy sheets. These codes are virtual check-in codes. They are to be used with existing patients, and it's not supposed to be tied to anything between that patient-provider relationship in the previous 7 days or the next 24 hours. So the way I read that and the way I interpret it, and Desmond, if you think differently, let me know, is if you have a patient that you're going to screen to see if they need to go get tested for COVID, and you decide during that brief check-in that you're going to send them to go get testing, well, then some people think, well, if you go send them to a different location, you can still bill this check-in code. I don't know. No, I haven't seen any clear guidance on that. So maybe you can, maybe you can't. Regardless, it's only about $15. And you guys would get paid 85% of that. So these are out there if you want to use them. Again, this is probably not something you're going to use right now, but you might. And if you decide you like telehealth and you want to get into this, you might continue to use these things. I don't know if anybody in here works for an FQHC or an RHC, If you do, you probably know that you always have special rules. I'm not going to get into it because I don't think we have that in the audience. If we do, please let me know and I can go into detail on it. But there's more information both on the CCHP website and the UMTRC website. All right, so now we're going to move on to the state of Illinois. And this is normally pre-COVID. Illinois reimburses for live video telemedicine and psychiatry service. You see the list of specific providers: physician, physician assistant, podiatrist, advanced practice nurse, very similar to the Medicare list. You have to be licensed by the state of Illinois or by the state where the patient is located. So for example, if you're in Chicago and you're seeing patients in northern Indiana, you need to have an Indiana license. That is for your own protection. It's for liability reasons should there be a bad outcome. Illinois Medicaid, I mentioned the place of service 02. That's what Medicare asks for on the bills. Illinois Medicaid asks for the CPT code that you would normally use in person with the GT modifier. There is one area of Illinois law that says that they reimburse for store and forward, but there's nothing specific in Illinois Medicaid about it. Something cool, I don't know if you guys would ever get into this. Illinois now covers home uterine monitoring. There's some special criteria around that. And right now, Illinois, well, so right now during the wave, this pandemic, all insurance companies are mandated to pay for telemedicine as if it was in person. They're supposed to be waiving, if it's COVID testing, they are supposed to be waiving any cost share on the Medicare side or copay for commercial insurance. Illinois legislature does still have a bill, and I didn't look it up to see where it's at, but they were trying to get a better parity law in place because you see if they choose in this language here, and we had heard lots of stories about Blue Cross Blue Shield being one of the biggest payers and dragging their feet on paying for telemedicine claims. But not right now. They better be doing it or they're going to get in trouble. So this is, I've got a whole bunch of screenshots and I want to point out some specific items in the Illinois executive order that came out on March 19th. So you can use, and here again, this is the relaxation of HIPAA rule. You can use a telephone, so you can electronic or telephonic methods. Video technology commonly available on smartphones or other devices, FaceTime, Facebook Messenger video chat, Google Hangouts, or Skype. So those are what they call public-facing video conferencing platforms that are very common. You can use those right now, but if you're going to do this long-term, I don't recommend them. And then here it talks about all insurance companies. We just talked about this, that the private payers are, they better be reimbursing right now for this executive order. And then, so here, insurers, so there's your insurance companies, may establish reasonable requirements, including with respect to documentation and record keeping. Make sure you document these visits. Make sure you keep records. If you have access to electronic medical record, use it. Do the best that you can under the circumstances. This next page here, talking about preventative services. So, and this, I mentioned this already, that the issuer doesn't have to pay for a charge for services unless it's deemed a preventative care. If it's, yeah. And then down here talks about substance use disorders. I don't know if any of you have the DEA waivers from to prescribe controlled substances, but there are some special DEA waivers going on right now. Existing insurance laws apply. Let's see, what else? So here again, these accepted benefits does apply to limited dental, limited vision. Here was the distinction between in and out of network. So the insurance companies, basically, it doesn't matter if you're in network or out of network, they have to treat it all the same right now. Information Developmental Disabilities Act. And then this I really wanted to point out up here. So you can use audio or video communication technology for telehealth services. Any non-public facing remote communication product is okay. But they do not want you to use Facebook Live, Twitch, TikTok, which are public facing. They don't want you to use those because they're not private. It's the whole HIPAA thing. Also in this executive order, we see that they are waiving. So if you've had a suspended license or has been lapsed or inactive for less than 3 years, they'll still allow you to practice. And we're seeing this all over the country, that specific licenses are being extended throughout this particular period. And you can see all of the different executive orders from Illinois at this link. Anything else you want to add on this, Desmond?
I mean, I think the executive order really potentiates telehealth in a way that we'd like to see on a longer term basis. The language largely in this order mirrors a bill that came up in the Illinois legislature earlier in 2019 that just didn't pass. And essentially this bill kind of does, or this order does what that bill would have done. I'll be perfectly honest, I think Illinois' telehealth billing, reimbursement, payment parity laws, et cetera, as they exist prior to the emergency declaration and this executive order are actually not very good. When we think about surrounding states, Illinois is not best in class. The bill as it was written, and I'm going to get the number wrong, but I think it was ILSB 27 when it was in session, and it'll come up again. It will get Illinois to kind of best in class with other states that are really at the leading edge. But the executive order, as far as telehealth utilization is concerned, in combination with the emergency declaration and what it does for PAs, which is a couple of things. One, lets a PA practice without a frank Illinois state license, although presumably everybody here has an Illinois state PA license. And two, it largely suspends a lot of the traditional collaborative requirements, which, you know, again, Illinois is a really good practice environment for PAs, but the emergency declaration basically says, you know, you're not going to be held to the standard of collaboration in the state as you're executing on, you know, patient care. Obviously, you should use your due diligence. You should make good clinical decisions. You should provide good care, and you should collaborate where it makes sense. But the law is really on your side as far as PAs are concerned, both in telehealth and in general clinical practice right now.
Absolutely, I agree. All right.
If I can briefly, we got
Sure.
some of these questions coming up, which Becky's done a nice job, I think, proactively addressing and will answer. We do have a couple of specific FQHC questions. I really do want to reserve some time to dive into that because I want to make sure that that's attended to this evening as well.
Let's go ahead and do that now. Really, the sad story is, and I think I've got it on a slide towards the end, there is a bill in DC, in the Senate, that was passed that is now in the House. The House has not voted on it today. The Senate voted on it late last night. It would allow FQHCs to be a distant site for Medicare, which would be a total game changer. In the state of Illinois, thankfully, and a lot of other states, Medicaid does allow you to be either the distant site or the originating site. The thing with Medicare right now, and this is our population that is most at risk during this particular disease, this time. If the patient's at home, and even if the clinician is in the FQHC or RHC office, then that makes them the distant site provider, and Medicare doesn't allow that. What we're also hearing is, Illinois uses the term encounter rate clinic because RHCs and FQHCs get paid at an encounter rate, which was developed from a cost report. And what I'm hearing from Medicare is that if this bill passes, fingers crossed, or when it passes, I should say, they're not going to get their all-inclusive rate for telemedicine. They're still only going to get paid fee for service. So I haven't spent any time looking at the group chat. Does that answer the FQHC question that's out there?
Yeah, go ahead, and if there's any outstanding FQHC specific questions, Becky is really your resource here. So go ahead and throw them out there.
All right, I'm going to go ahead and go on, and then certainly my email will be at the end, and certainly we can follow up on any specific FQHC or RHC questions. All right, let's go through some prepared questions that we have and see if they help. Do we need any special credentials to provide telemedicine? Well, you have to be licensed in the state, and we talked about that already. But there's not a special credential for telemedicine. What equipment do I need? We've kind of talked about that too. I recommend video capabilities during this particular crisis. You can use telephonic methods. I don't recommend them. You can get a lot from a patient just looking at their facial expressions, that type of thing. Do you need a headset? If you're just doing a conversation, unless you're trying to block out noise or you have a hard time hearing. You don't, depending on the platform that you use, really dictates if you need a smartphone or a tablet or a computer or what have you. If you decide to do telemedicine on a regular basis and you get into an area where there is a medical assistant or somebody with the patient that has a digital stethoscope, then you're going to want to use a headset so that you can better hear the auscultations. Is telemedicine appropriate for all ages and or specialties? There are some things that really lend themselves, anything that's conversation based. If you're following up on an ortho visit, if you're kids love it because they use FaceTime and all kinds of video platforms to talk to their friends and their grandparents, and older people, they really like it too. If you've got somebody that's phobic in a behavioral health situation, they don't want to leave their house anyway. Forget what's happening right now. And especially with behavioral health, there's been a lot of incidental information, stories, anecdotal stories that patients feel safer because they can stay in their own home to talk about their problems instead of venturing out to a strange place where they don't feel as safe and secure. But use your best judgment. Can telemedicine be for new patients or only established patients? Right now, absolutely anybody you can do a telemedicine visit with. Now, I mentioned DEA waivers. There are some restrictions around prescriptions for controlled substances. Those have been waived for right now. Can I order outpatient tests or labs for a patient during a telemedicine visit? Yes, absolutely. Can meds be prescribed? Yes, especially if you're talking about antibiotics, for a sinus infection or what have you. So here's my information on controlled substances. We do have the link, and if we have time, I can actually show that site live, and we could put that URL in the chat. But yes, so you can prescribe on the initial video visit, even if you haven't been seen, or the patient hasn't been seen in person during this particular waiver. But prior to the waiver, in order to issue a controlled substance prescription via telemedicine, there had to be a provider-patient relationship established in person before renewing that prescription via telemedicine. How do I perform a physical exam? So this is an area where you really have to be creative. A lot of patients, especially if you're seeing elderly patients, probably have a blood pressure cuff at home. They can take their blood pressure and tell you what numbers they get. They can show you, what numbers they're getting on the readout. Just about every family has a thermometer that they can take their temperature. They can show you, fitness devices. A lot of people wear fitness bands, or maybe know how to check their pulse. They can tell you that information. Document as best you can. Follow your organization's protocol. If they have told you, when you're doing your clinical exam, if you're not actually taking those vitals, or another medical professional is not taking those vitals, if you need to make a note of it, that you're relying on patient information. What if the patient then needs to be seen in person? So, you're doing a screening, you think they might be positive for COVID, and then you decide they need to go get tested. Follow your organization's emergency preparedness clinical protocols. And telemedicine is not a different clinical service. It's just a different modality of connecting that patient provider using video conferencing. If an in-person visit is determined necessary, can I still bill for a telemedicine visit? Yes. Now, in that case, the virtual check-ins, I'm not sure if it'll get reimbursed or not, but bill it, absolutely. Reimbursement should be the same in person for the insurance being billed. So you guys know this. If, I'm going to make up some numbers. If inpatient visit is $150 that gets billed to Blue Cross Blue Shield, and they pay $120, Medicare might pay $80, and Medicaid might pay $60. It's going to depend on what insurance is being billed. One more page of questions. How long should the visits be scheduled for? Well, how long do you make your normal visits scheduled for? It's the same clinical service. Does my collaborating doc have to do anything with these visits? Same collaboration rules apply as in-person visits, but we've seen a lot of waivers for this, and Desmond spoke to this. This is an unprecedented times. We're kind of making the rules up as we go along. We're doing the best that we can with what we have. Make sure that you talk to your organization, see what protocols your organization has in place. Once this pandemic is over, do I lose my ability to provide telemedicine services? No, absolutely not. Even before this, PAs were recognized and reimbursed through Medicare and through Illinois Medicaid. I think that's all of our questions. Oh, I just had a couple things. If you wanted, Desmond spoke about and I think I got it on here. Telehealth insurance coverage. There's a House Bill 4963 that is current in the 2020 Illinois legislative session. So if you go to cchpca.org and you click on telehealth policy and current legislation or something like that, you'll see it and figure it out. But you can drill down by state. There's currently 17 bills that are telehealth related in the state of Illinois, and that does include this executive order here that we just went through, Executive Order 2009. I had one other slide. So again, I mentioned that we have a lot of COVID information on our website. So it's UMTRC resources and COVID-19. We've got it broken out by state here. Then there's some HRSA things. I believe that the DEA, I'm probably going to get in there tomorrow and change it. So the DEA has its own header, but I think it's under HRSA right now, or maybe CMS on the second page. I told you how to get in touch with us. There is my email address. So I know that lots of stuff's been going on in the chat. Desmond, if you had a chance, or Anita, do you want to kind of guide us through this?
Well, I've been kind of answering questions real time, and I want to reserve a couple of minutes for Anita to share important updates from IAPA. I'll say a couple of things to kind of wrap us up since we're running out of time for questions live. And then I'm going to offer my email address directly for anybody here who wants to connect outside of the talk as well. So let me encourage or hand it over to Anita if she wants to take a few minutes here as well.
Oh, sure. Thanks, Desmond. Um, I just wanted to let everybody know we have a couple of things going on at IAPA right now. We are putting on this series of conference calls for you guys, our members, just to keep you up to date during this COVID-19 pandemic. Last Sunday, we had infectious disease PA Tricia Heaslip. She talked about coronavirus. Diagnosis, management, treatment. It was a fantastic presentation. We had about 65 members join for that call. We have tonight's call, which has been an excellent overview of telemedicine and virtual medicine. Next week, we have an upcoming talk called Achieving Mind and Body Wellness, Integrative Approaches to Support Your Mind and Body During Times of Stress. This will be hosted by Chicago area functional medicine PA Crystal Bauer. So look for some information about that in your emails. Currently, we are also involved in the Patients First initiative. This includes Senate Bill 2758 and House Bill 4692. The purpose of those bills are to advance PA practice rights here in Illinois by removing some paperwork requirements and allowing PA scope of practice to be determined at the practice level. Additionally, that legislation seeks to create a PA regulatory board as well. That'll allow us to have greater input in the regulation of our profession. If you want more information about that, you can go to patientsfirstillinois.org, I believe. We'll have that on the IAPA website. It links in there. So illinoispa.org will get you there as well. We just want to wish everyone health and safety in the weeks to come. IAPA is here to help with any questions or concerns you have about practicing in Illinois in regards to COVID-19 pandemic or otherwise. So Desmond, I'll kick it back to you and you can kind of take us out here.
Great. Thank you for that. Before everybody drops off, a couple of highlights that I really want to make sure you're walking away with. Regardless of what your role is within telemedicine right now, whether you're already doing it, you're planning to do it, you want to launch it, you're getting forced to do it at your employer site, whatever the case is, there's some really important things to take home. One, telemedicine is medicine. You all practice medicine already. This is the application of those principles in a slightly different setting. So it's really important to kind of engage with that and sort of simplify what this truly is. This is the practice of medicine in a different venue. And then two, a lot of you are going to be experiencing pushback from employers or, we're really not sure if we can do it right now, or we're worried about the money and we're worried about billing and we're worried about legislation, and all of these things are reasonable concerns. I think to an extent, hopefully we've answered a lot of these already tonight, but there's two things I would encourage that you take back to your employers or whomever when those questions are addressed. One being, we're not getting paid for the visits that we don't have, first and foremost. So if you're already shifting and losing a lot of office-based encounters because of the realities of what we're facing right now, it's really time to investigate and engage in telehealth and get that set up. It's simple to do. And then last but not least, your patients are never going to forget the way that you supported them during this time, good or bad. So it's really critical that you think about the relationship you're trying to maintain with your patients now and beyond. And to Becky's point, as we engage and invest in telehealth, there is going to be a lot more of this moving forward. This is not just for now. And I think as the dust settles, we're going to see major change legislatively, billing, reimbursement in a way that's difficult to predict right now, but we can confidently state is going to move to a more positive place. So we should really begin to anticipate that clearly. So a couple of comments that have been coming in just as a reminder. Dan Shulman's with us tonight. He's worked tirelessly for the PA profession in Illinois for quite a while, and he's been our lobbyist for IAPA for a long time. And we're working on expanding practice authority with additional emergency language, emergency measures that are really going to expand our ability to effectively serve our patients. I think everybody in the PA profession wants to see these things remain in place for as long a period of time and beyond. And so IAPA is truly your advocate. And then last but not least, Becky, I am sorry I didn't get it on the slide, but I'm going to put it into the chat. My direct email, which you are welcome to use, and I'm happy to answer telehealth related questions for anyone and everyone, is there. I can't get back to everybody as fast as I would like because we're fielding a lot of inquiries right now. And then finally, I want to thank Anita for really doing a wonderful job bringing this series together. IAPA cares about serving its members and all of you. And Anita has really done an amazing job leading the charge on this to bring valuable content to members now on an ongoing basis. So I just want to thank Anita for the work that she's doing.
Oh, thanks, Desmond. Appreciate that.
Yeah, there's one quick thing, and I'm trying to go through the group chat here, that I want to make sure, because it'll be on the slides that you'll get. Section 4 of the Illinois Executive Order says, health insurance insurers shall not impose any cost sharing, co-payment, deductible, or co-insurance for telehealth services provided by in-network providers. However, if they have not met their deductible under their terms of coverage, the requirements of this section do not require an issuer to pay for a charge for telehealth services unless it's associated for that particular charge deemed preventative care. And preventative care includes, the IRS recently recognized that services for testing, treatment, and potential vaccination for COVID fall under preventative care. So I think what that means is the government's going to pay for it. I don't know, but I don't think that. I definitely think that the patient doesn't pay for it. Anything right now related to COVID, and it also kind of sounds like that maybe the healthcare organization is the issuer. That doesn't have to pay for that charge, so the insurance company is out that money. I'm not quite sure how to interpret that, but I saw that as a question, and that language isn't really clear. So.
Yeah, there it is, clear as mud. And at the end of the day, Sarah Copeland, good call. That's part of the rule right now in telemedicine is there's a lot of uncertainty and a lot of lack of clarity, but frankly, a lot of you don't have a choice. And we don't mean to say that you're between a rock and a hard place. We mean to say, kind of got to do it, and we got to figure it out, and we have to make it work for patients, providers, organizations, and something to sustain and grow into. And that's really what we're here for. Let's continue the conversation offline. Again, I've shared my email. You certainly should know how to be in touch with the IAPA, and we're really here to support you, and we want to thank everybody for your time tonight.
Becky and Desmond, thank you so much. It was a great presentation.
Thank you.
Take care, everybody. We'll see you on the next call. Bye-bye.